من Dr. Elnahas. He will run everything and he will give us a lesson. So listen.
So we'll spend just 5 or 10 minutes to summarize what you've learned, as much as possible of what you've learned over the last 3 days. I must say this has been one of the most comprehensive acute kidney injury workshop and study CNE days that I have attended. So it was very comprehensive, nicely balanced and in depth, and I think you would have covered all aspects of acute kidney injury. So the take-home message is, I think again we've covered the fact that acute kidney injury is very common. Acute kidney injury is a global problem, and we discussed at some stage the etiology of acute kidney injury in developed and in developing countries. And we said in developing countries we have hygiene, we have water sanitation issues, we have water quality, we have pollution, we have infections. 200 million, we heard today, 200 million individuals every year is suffering from malaria. 1 million individuals, mainly in Africa, is dying from malaria every year, and many of these are dying because they have acute kidney injury. So very high mortality in the West, where we treat people with acute kidney injury who are very old, who have a lot of comorbidities, diabetes, hypertension, cardiovascular disease, but also very high mortality in developing countries where you have infection as the major cause. And the other problem Professor Osama touched upon is the fact that in developing countries, many sub-Saharan African countries don't have renal replacement therapy. We touched upon the overlap between acute kidney injury and chronic kidney disease, and more we need to be aware of these permutations. Patients with acute kidney injury who have normal kidney function, who don't fully recover and continue to have residual chronic kidney disease. Patients who have chronic kidney disease had a superimposed acute kidney injury insult, therefore their kidney function further decline, or an injury or an insult that can cause acute and then in the long term chronic kidney disease. So become more and more aware of acute kidney injury as potentially a major cause of chronic kidney disease. فلما الناس تسألكم ما هي أسباب chronic kidney disease؟ الأسباب اللي احنا عارفينها hypertension, diabetes, glomerulonephritis، بس ما تنسوش في الامتحانات تقولوا acute kidney injury. And more important, acute kidney injury is preventable, and again in developing country preventable by treating infection, by improving quality of water, by improving sanitation, by avoiding herbal remedies. You heard about herbal remedies, avoiding toxins and so on. And acute kidney injury is treatable, and you've heard all different scopes, including today in particular, of non-dialytic management of acute kidney injury, how nutrition is important, how general hydration is important, treatment of sepsis is important, stopping nephrotoxic drugs. I've shown you a slide in the UK where more and more hospital-acquired acute kidney injury is due to ACE inhibitors, angiotensin receptor blockers in all cardiovascular diabetic patients. And then you've heard a lot about different modalities, when to start, early, late, when to stop, how to dialyze, intermittent hemodialysis or replacement therapy, continuous renal replacement therapy, SLED, slow, high flux, and very important what Osama, Professor Shahad said about CAPD. 30 years now we forgot about CAPD as a modality for acute kidney injury management. You may not need it in a big teaching academic hospital, but as we said as well, there are patients you can't hemodialyze. So at the end of the day, you said the systolic is 80, the patient is in shock, he's 30-year-old, we leave him to die because we can't hemodialyze. And we forget that there is the option of it's not CAPD, but peritoneal dialysis, automated continuous flow peritoneal dialysis. And the International Society of Nephrology, as I said before, is making a big drive to save lives all over the world by introducing PD again as the treatment of choice in countries where hemodialysis is not available for acute kidney injury. Management, AKI, is preventable, so try as much as possible to minimize nephrotoxic drugs in all susceptible at-risk individuals. We talked about who is at risk over the age of 65, comorbidities, diabetics, atherosclerosis, cardiovascular disease, and people who have underlying nephropathies. So you don't want acute on chronic. It is preventable, but it's only preventable if you always think AKI, if you always think nephrotoxicity. AKI is detectable because now we have all these new classifications which allow you for earlier awareness of patients with impaired kidney function and acute kidney injury. And maybe one day we talked about biomarkers may also point towards people at risk. I'm not sure you'll treat somebody because his NGAL or KIM1 or IGF binding protein is raised, but it will tell you this is a patient who is at risk, and we've heard about kidney angina and pre-acute kidney injury, and therefore you detect the early stages of at risk, and therefore you prevent the old-fashioned acute kidney necrosis. I still like the old classification, pre-renal, renal, and post-renal, because pre-renal told you, almost like the AKI angina, that this patient is at risk of developing established AKI. So you rehydrate and you resalinate and so on. And AKI is treatable. But the most important point highlighted by the talks today and the talk of Professor Tare is you have to individualize the treatment. And that is the problem with clinical trials in acute kidney injury. Most clinical trials, sometimes they tell you there is a difference between high volume replacement, low volume, early versus late, IRD compared to CRRT, and then you get opposite trial telling you there's no difference. The population is so heterogeneous, so difficult to do a clinical trial on patients with conditions such as acute kidney injury. So the guidelines, and again we've seen the arrows, not graded, not graded, not graded. All the recommendations are based on personal experience. And you heard Tariq again, early treatment in high-risk people, early treatment in catabolic patients with AKI, and you heard Russia comparing early and late and going over the different stages. But somebody who is at risk, somebody who's hyperkalemic, somebody who's severely acidotic, somebody with pulmonary edema, there's no discussion as to whether you wait another day or two. So personalize the treatment, individualize the treatment based, as we said, on the patient, but also your local facilities. So if your ITU is expert in SLED, then just do SLED. If they're expert in intermittent hemodialysis, don't tell them do CVVH because they won't be able to do it. So personalize everything to do with acute kidney injury. The way forward, increasingly, and we discussed this yesterday, acute kidney injury comes to the nephrologist for renal replacement therapy, but it's not the nephrologist who sees the patient first. And you've seen the data from 3 or 4 years ago in the United Kingdom when they analyzed acute kidney injury and concluded that 78% of AKI management in the UK is substandard. Poor. Why? Because the patients go to general hospital where there's no nephrology. They may be seen by primary care physicians who have no experience in nephrology, non-nephrologists in different hospitals. So I think there is a lot to do for us, not just in treating acute kidney injury, but training, educating non-nephrologists to detect, prevent, and refer patients with acute kidney injury to nephrologists. So we need better education, better awareness, and having systems, I guess, in different hospitals with potential lab alerts, so when a cardiologist realizes that the creatinine has increased by 50% or by 0.3 milligram per deciliter, he reacts. When an obstetrician gets the same message, and so on and so forth. And again, that's one thing they're setting up in the UK, links between the labs and different departments to flag out people at stage 1, stage 2 acute kidney injury. It doesn't take much. You get the result with a little red flag. And then the non-nephrologist say, what's the red flag for? It is to draw your attention that this patient has a significant increase in serum creatinine. And I think it would be useful for most renal units and most hospitals, even when there isn't a nephrologist, to have somebody who can be labeled as acute kidney injury lead. He doesn't have to be a specialist. All he has to do is perhaps even get the alerts to his laptop, perhaps get notification to his office, educate doctors, educate nurses, and so on. So I think having an acute kidney injury lead is something hospitals are looking for within the UK, whether it's an intensivist, whether it's a nephrologist, or whether it's just an internist who takes that responsibility. But nephrologists can't do everything, so we need help, and the best way to be helped is to have a system in place. AKI research, and I'm thinking of AKI research in Egypt, and AKI research, I'm not going to talk about nanomolecule or micro RNAs or epigenetics. I'm thinking more of practical quality assurance for your patients with AKI. In your hospital, in your town or city, you need to be more aware of the populations at risk. These may be people who take AKI. These may be people who work out in the heat and get easily dehydrated, and put more emphasis on at-risk population. It would be nice in your hospitals if you have an acute kidney injury database. Just have a good recording system of patients who have acute kidney injury in your hospital. And if I ask any one of you, do you have in your hospital an acute kidney injury database? My guess is the answer will be no. This would be useful because it will give you the profile of the patients, when they come, whether they come early, whether they come late, whether you treat them early or whether you treat them late, and the outcome of these patients. And the essence of good clinical governance, audit, is to know your patient, to know what you provide them in terms of management, to know the outcome of your management and see if it's good or bad. It can't be perfect, so there will always be room for improvement. So you will always want to have an audit cycle every year, every 2 years, and this is where the acute kidney injury leads. Whether it's a junior doctor, whether it's a lecturer, whether it's a professor who looks at the result. We practice too much medicine without knowing outcomes. And it's just unbelievable. If you are in a business and you run a factory and you don't know the outcome, you don't know your productivity, you can't run the business. But we run the business of treating people, and we have no idea how many AKI we treated last year, how many AKI survived, how many AKI were not treated, and how many died. Do you know in your hospital, Osama, how many AKI you treated last year?
Well, since 3 months, I hire one person. He's sitting here in Harvard. I hired him and did nothing. I hired him and to collect the data, I give him the sheet, I give him everything, but he did nothing. My fault,
But it is important, at least you had the idea and you took the initiative to set up the system. مش هنجيب اسامي مش and management guidelines. I think the problem with management guidelines in general in nephrology, they are too West and high income countries orientated. They tend to be written in general by Western nephrologists, mostly by American nephrologists, to a large extent by European nephrologists, who are all very often also working as consultants to different drug companies, so there's always a concern there. But it's irrelevant. You have to have your own guidelines for your own renal unit, based again on your own expertise, your own facilities, your own infrastructure. There's no point doing SLED if you don't even know in your hospital what SLED stands for. So you need to be practical and have your own management guidelines. You can read the other guidelines, you can draw from the other guidelines, but you need your own guidelines. There's no guidelines here in Egypt from the Egyptian Society of Nephrology and Transplantation, but nothing stops you to have guidelines for Mansoura, or even your own Mansoura nephrology and dialysis unit, or the International Hospital, or the Institute of Urology and Nephrology, whatever. And I think we need to be a bit more critical and independent from international guidelines. International guidelines are guidelines. Then you apply your critical thinking. Do they apply to my patients? Do they apply to my resources? Do they apply to my country? And very often the answer will be no. Finally, I would like to thank you all for inviting me. Thank Maggie once more for being very generous and inviting me, and for Mustafa for doing a wonderful, wonderful job in organizing the meeting. We said earlier on about the remarkable example and role model you have in Nagy here as a role model, not just as an excellent nephrologist, not only as an excellent educator, but a caring father figure, or big brother perhaps, a caring father figure for all you juniors working here with him at the Mansoura Nephrology and Dialysis Unit. And amongst them, I was really impressed by all of you and Mustafa for his thoroughness, keeping to time, his discipline, his organization skill, and more important, his enthusiasm. The country is going through a very difficult phase, and we need more and more people who are optimistic, who are realistic, and who will not give up. And this man is one of them. The Global Kidney Academy would like to award you with its prize of a free registration to its transplantation online course that will start in May. Well done. Thank you very much. And finally, thank you to everybody. And
indeed, I cannot find words, enough words to thank you. You've enriched our thinking, you enriched our science and our practice. So you your invitation, I invite you openly to be among us every now and then. Please come again and again and again.
It would be a pleasure. Right. The science is good, the social program is good, and the food is excellent.
كده حاولت انا كده
ازاي حضرتك؟